AREP in Academic Radiology Education Program. We broadcast radiology webinars to Asia, to the Middle East, and to Africa on the first and third Sunday of the month. And this is a sharing knowledge between and expertise from the West to the East. And this is our special session from in cardiothoracic imaging, because we get a help, a collaboration from a Society of Thoracic Radiology. So every single of us, a cardiothoracic imager here in the United States, are member of this society. So it is a great honor and great pleasure here to be able to collaborate with STR. And I would like you, I hope that you enjoy the webinar and get something out of it. I'm going to pass this on Dr. Rem. He's going to be our moderator today. And don't forget, at the end of the webinar, we will have a survey. People who are going to do the survey will get the certification of attendance, and we'll have a quiz question. The quiz, you will get a prize from your quiz question. So today I'll give you a little bit more time, 2 minutes instead of 1 minute. Last time we were complaining about the time that is not enough. So today we're going to be 2 minutes. Okay, Dr. Ram, please.
Okay, thank you, Nate, for the opening remarks. Dr. Geoffrey Rem is my name. Good morning, good afternoon, good evening from wherever you are attending from today. The Academic Radiology Education Program. Our topic today is imaging approach to pulmonary embolism. I am moderating all the way from Uganda. My affiliation is Makerere University. Without further ado, I would like to introduce our guest speaker for today, Sanjeev Bala, MD. He doesn't need an introduction, but for the purpose of this meeting, I'm going to go ahead to try to introduce you to him. He has an impressive CV. I'll try to run through a summary in a few seconds. He's born in Chicago, Illinois, had his undergraduate education at Yale University, New Haven, Connecticut, and had his graduate education in Columbia University, College of Physicians and Surgeons, New York. Thereafter, had his internship in Columbia Presbyterian Hospital, Department of Internal Medicine, New York, and proceeded to do his residency in diagnostic radiology at Mallinckrodt Institute of Radiology in Washington, and thereafter had his fellowship in thoracic imaging at the same institution. He has had university and hospital employment for about 25 years now and counting. He's a professor of radiology, a pioneer in lung cancer screening, chief cardiothoracic imaging section. He's also a co-chief body imaging CT, and then he works at the Washington University Mallinckrodt Institute of Radiology. Before I finish his introduction, he has multiple honors and awards and editorial responsibilities. He belongs to multiple professional societies and organizations. He has over 180 journals in peer-reviewed, manuscripts in peer-reviewed journals. And he has about 14 book chapters and affiliations. He has over 170 invited lectureships. This is national and international, and also has several local and regional lectureships. Ladies and gentlemen, I invite you to welcome our guest speaker, Sanjeev Ballad. Over to you, Dr. Ballad.
Well, thank you very much for such a kind introduction. It's always tough to try to live up to expectations after you give such kind words. Good morning, everybody. It's a real treat to be with you for the Academic Radiology Education Program. I am a former president of the Society of Thoracic Radiology, and it is, for me, one of the greatest groups of people that I've ever joined. I would also encourage you, if you can, to visit the website, because we do have quite a few free programs available online to go through a core curriculum in cardiothoracic imaging. So let's get started on talking about imaging of pulmonary embolism. Today, I wanted to just highlight what is meant by acute pulmonary embolism to improve your confidence. And I will say that I have no financial disclosures. So acute PE represents the third most common cause of cardiovascular death in the United States today. Number one is myocardial infarction, number two is stroke, and number three is PE. They say that greater than 300,000 deaths a year in the United States can be attributed to pulmonary emboli. And we're all aware as radiologists that there are various modalities that can be used, CT, MRI, and VQ scans. But really, despite them all having various sensitivities and specificities reported in the literature, the CT has really become the standard because it's easy and it's fast. I should also mention that PE, though it is life-threatening, can be incidental. I think many of us who image in cancer centers know that only in about 3 to 5% of patients with cancer, you may incidentally pick up a pulmonary embolism, and it's also pretty common. This is a statistic from the CDC in the United States. They publish every year causes for emergency department visits, and you'll notice that the most common causes of emergency department visits in the United States include chest pain and shortness of breath, two symptoms that are very common associated with pulmonary embolism. And I think we all are aware of the various risk factors, including old age, prior pulmonary embolism, bed rest. If there's no known cause, we call this idiopathic or unprovoked. And here, for example, was a patient who had no known cause and came in with acute pulmonary embolism. So the risk factors are known. Sometimes they're not very helpful. And people have talked about using various pretest probability scores. The prediction rules that are out there include the Wells criteria and the Geneva criteria. We tend to use a modified Wells, but you'll notice in the yellow arrow, if the clinical person ordering the study thinks that PE is the most likely diagnosis, you immediately get 3 points, and that puts the risk at moderate. And in our institution, what we have found is though there are, though we do have various prediction rules in place, what we've noticed is that many of these physicians ordering the studies don't use those prediction rules. So you may end up getting a CT even when the risk is considered low. Now, I know that we're all from various institutions around the world with various technologies, but I just wanted to share with you how we've seen some of the technology evolve regarding pulmonary embolism imaging. Here you can see this is a 4-row CT scanner, which is what we were using when I first started in my career. And as we started getting better with the technology, it became much easier to see lower lobe pulmonary emboli. And with our most recent scanner, this is the photon counting detector CT, you can see how nice and crisp pulmonary emboli can be visualized. So technology has really helped us see these better. Now, Nat had asked me to just touch base a little bit with dual energy CT, and I just wanted to share that in our institution, we do have dual energy, but we don't use it very often at all. The only time that we really found dual energy to be very helpful is when a patient cannot get a high amount of contrast. If they can't get a high volume, then you can do a PE protocol CT with a lower contrast dose. So our normal protocol will have about 100 milliliters of contrast that we administer with a concentration of 350 milligrams per milliliter of iodine. But when we use a dual energy, we can bring the contrast rate to about 35 milliliters of volume. And that's what this was. This was a patient who had had pulmonary fibrosis and a cancer. And the question was whether there was pulmonary embolism or not. And we were able to do this with a lower dose. And we could, because it's dual energy, you can create a monochromatic energy here 55, close to the K edge of iodine, and you could appreciate the vessel much clearer, even with a small amount of contrast. So for us, dual energy is about changing the visualization of the contrast more than it is about putting the iodine maps. Now, I want to share with you some definitions that have been kind of developed, that are starting to evolve as we speak with our clinical colleagues in cardiology, in cardiothoracic surgery, and in pulmonary medicine. These definitions include chronic PE, acute PE, subacute PE, recurrent PE, and in situ thrombosis. So in other words, not all filling defects are going to represent acute pulmonary embolism. So acute PE represents the migration of a pulmonary embolism into the pulmonary circulation. When it's associated with systemic low blood pressure, it's known as massive pulmonary embolism. If we see right heart strain on CT, but we don't have a systemic hypotension, that's called submassive pulmonary embolism. When the pulmonary embolism is old, that's old or subacute PE. And here in red is an example of an old PE. Notice that there's no pulmonary hypertension. When the patient has pulmonary hypertension associated with prior PE, this usually implies that there's been some cytokine-mediated scarring, and that's known as chronic PE. So chronic PE, as in this example here, represents more than just old PE. It represents scarring that happens from PE and subsequent pulmonary hypertension. Recurrent PE is where we have recurrent bouts of pulmonary embolism, and those are patients that may benefit from being worked up for a hypercoagulable state. And in situ thrombus is basically atherosclerosis of the pulmonary artery. It's something that we see in patients with long-standing pulmonary hypertension. So if you see a wall mural thrombus, it's possible that it's in situ thrombus. And each of these definitions will impact treatment to some degree. Now, one of the things that's true, and we teach our residents and our fellows at our institution, is that when we think about pulmonary emboli, I think most of us think about filling defects that are within the pulmonary arteries. But what I would like you to do is when you're looking at an embolism protocol CT, think about these three categories. Think about the cardiovascular findings, think about the pulmonary artery findings, and the lung parenchyma. Being aware of what's going on with the right ventricle, if there's bronchial artery enlargement, very helpful because pulmonary hypertension with right ventricular hypertrophy and enlarged bronchial arteries is not a finding of acute PE. Look at the filling defects. Are we seeing just a central filling defect or is it peripheral? Do we see webs? Is the pulmonary artery enlarged? Also, look at the lung parenchyma. Are we seeing clear lungs? Is there mosaic attenuation, bronchiectasis, nodules? All of these helpful in trying to make our diagnosis. And when we think about acute PE, this is how we can break it down. The pulmonary artery findings tend to be central filling defects, which expand the vessels. If the pulmonary embolism is peripheral, we'll have acute angles with the wall. We may see an enlarged right ventricle if there's right heart strain, but we will not see right ventricular hypertrophy. We look for infarcts. Sometimes you'll see oligemia, the so-called Westermarck sign, and bronchial arteries are not enlarged. So here, an example of acute pulmonary embolism, where the pulmonary artery is expanded from the central filling defect. Sometimes you'll see what's called a polo mint sign, where you get this contrast that outlines the pulmonary embolism, or a tram track sign, where the contrast is on both sides of the pulmonary embolism. Again, a 1, 2, 3 approach, very helpful, looking at the pulmonary arteries, central filling defects, expanded vessels. When we look at the right ventricle, in this case, it's enlarged. There's bowing of the septum. So this person has right heart strain. They did not have systemic hypotension, so it would be considered submassive pulmonary emboli. And you notice that there are peripheral infarcts. There were acute pulmonary infarcts. We look on our parenchymal windows for infarcts, and if you're doing dual energy, you may see that there's some decreased areas of iodine. We don't tend to use this very often. We find that it's very useful just to look at the gray images. But I do want to share with you this pattern here. This pattern, a peripheral airspace opacity, very typical of an infarct. Notice there's even some bubbly ground glass. I think many of us would say this looks very similar to a reversed halo that we can see with organizing pneumonia in another situation. But when the rind is thick like this, don't forget about pulmonary emboli. Here you can see this was a central filling defect. The reason I say that is because many times we are doing studies without intravenous contrast, and you might see this finding in the lung parenchyma. When you see this thick-walled reversed halo, then I think it's very important to at least consider is infarct a possibility. Occasionally, we'll see this kind of more ground glass peripheral finding that is typical. So here, an example. This is a patient who presented with right upper quadrant pain, and they started getting worked up for cholecystitis. And you could see when we look at the images, there's this peripheral ground glass. There's a little bit of that thick wall suggestive of that thick-walled reversed halo. We brought the patient back, and you can see that they did not have cholecystitis, but they had acute pulmonary emboli. So very good to look for those findings. Another example of a patient with an infarct here, where you could see that it did not enhance this thick wall. Below the yellow line, here is a patient who came in for colon cancer staging. And our original thought was that we may be dealing with a metastasis in the left lower lobe. You can see this area here. But again, it's peripheral and it's somewhat irregular. And those of you, and I know there are many of you who are watching who've got very good eyes, notice that there's something irregular about the pulmonary artery in the non-contrast study. The patient was brought back, and in fact, it was not a metastasis. It was a patient with acute pulmonary embolism. So remember, infarcts tend to be peripheral. Infarcts tend to be kind of this thick-walled reversed halo with some areas of ground glass. Now, we had mentioned that there was this entity chronic PE, and I just would like to contrast chronic PE with acute. So chronic PE is much more likely to result in parenchymal mosaic attenuation, very different. This mosaic attenuation represents hypoperfused areas of the lung, and this is really needed to make the diagnosis of chronic thromboembolic pulmonary hypertension. Because it's pulmonary hypertension, we see big pulmonary arteries, big right ventricle, but there's right ventricular hypertrophy, which tells us that there's been long-standing elevation of pressures. Notice that in this patient who had had massive pulmonary embolism because of systemic hypotension, the right ventricle is enlarged, but there's no right ventricular hypertrophy. Bronchial artery enlargement, very typical of chronic PE, absent with acute PE. Now, just a word of technique. If you're interested in looking for the bronchial arteries are usually found at the level of T4 to T8, and they can be really highlighted with coronal maximum intensity projections. So we tend to do coronal maximum intensity projections 4 to 7 millimeters, and we look in the region of the subcarinal space to show these enlarged bronchial arteries. One of the questions that sometimes comes up is, what prognostic indicator is most often used? Is it the Conodley score? Is it an RV to LV ratio, coronary sinus size, or decreased LA volume? And as you've already heard me say, really it's the RV to LV ratio. I want to really emphasize that there are scoring systems that are in the literature, but what I'd like to highlight to you is that these scoring systems really aren't practical. They're not used in clinical practice across the United States and across the world. They're more for research papers. Really much more useful is to look at the RV-LV ratio. Now, at our institution, we'll try to correct for the long axis of the heart with multiplanar reconstruction. But even if you don't, if you're just looking at an axial data set, and if the right ventricle starts to exceed a ratio of 0.9 to the left ventricle, then we start to worry that there's right ventricular enlargement. And we look for findings like this, where there's septal bowing. There's even in this case, you can see that there's starting to begin of a patent foraminal valley, which is very, very useful. So in purple, these are all the things that we don't tend to use very much. We tend to really rely on this RV to LV ratio. It's said to be 1 if you're not doing multiplanar reconstructions, and 0.9 if you are, to do a 4-chamber corrected view. Occasionally, you'll see increased venous collaterals, and that's because the RV pressures become so high that the contrast will go through the venous collaterals. Another example of a patient with acute pulmonary embolism. This person did have systemic hypotension, so this was massive pulmonary embolism, and you could see the big filling defects. You could see the enlargement of the right ventricle. Again, notice that there's no right ventricular hypertrophy. Again, notice that there's the development of a patent foraminal valley, and this patient went on to get treatment. Another example, this is a patient who had a acute pulmonary emboli with right heart strain. You can see the right heart is big. In fact, in this patient, there was the thrombus that had a deep venous thrombus, which had migrated to the right atrium. And what's difficult to appreciate was this thrombus was starting to cross over a patent foraminal valley. That is sometimes known as a patient who is this patient is known to have something called thrombus in transit. Now, I do want to just highlight that there is a question that sometimes arises with pulmonary embolism evaluation about what about the pregnant patient? What should we be doing with pregnant patients and pulmonary emboli? And the thought has always been that if you can do a VQ scan, the VQ scan is a better study because it's lower radiation to the mother. It is about something along the order of 5% lower radiation to the mother and it's 20% lower radiation to the breasts. And so the thought has always been that to do a chest radiograph first. If the chest radiograph is clear, then to go to VQ scan. But the reality is, for most of us in many centers, the VQ scan is not readily available, or it's not something that's routinely offered. Some of the things you can consider in a pregnant patient to bring the dose down a little bit is to reduce the Z-axis. Studies have shown that if you begin at the level of the arch and go to the base of the chest, then you can reduce the dose because you decrease the length, so the dose length product is reduced, and this reduction in length results in significant reduction in dose by about 20%, and studies have looked to see if any clinically significant pulmonary emboli would be missed, and they've demonstrated they have not been. So if you have a young patient or a pregnant patient where you're trying to reduce the dose, consider starting at the arch and getting to the bottom of the posterior sulci. The other thing that you can do is you can lower your KV to 100, and you can use a high pitch. So when we use all three of those, low KV, high pitch, and reduced dose, we're able to bring an effective dose of 1.1 millisievert. Now, if you're like me, you may say, well, what does 1.1 millisievert mean? Well, 1.1 millisievert contrasts to a normal chest CT, which is about 5 to 7 millisieverts. And keep in mind that annual background radiation dose is about 3 millisieverts. So this is less than 1 year's worth of radiation. And that's pretty good. That if you're engaged in lung cancer screening CTs are about 1 to 2 millisieverts. So this puts it right at the right range so that we can make a diagnosis without over-radiating our patients. Here, just an example, this was a patient who we began with a VQ scan. There was some perfusion defects, and there was some thought that this was an intermediate study. This patient has congenital heart disease and was pregnant, so we brought her back for a CT, and even using the techniques that we had, you could see that the CT had an effective dose of 2 millisieverts and still very good diagnostic quality. Now, in the United States, one problem that we face is obese patients trying to image patients who are obese. And I'll tell you, this can be a real problem, especially in patients where the BMI starts to exceed 45. Here is an example. This is a patient with a BMI of 59.1, so quite obese. And you can see that the problem that you face in these larger patients is that they are prone to artifacts on CT. And so in these patients, we found that VQ is actually a very good study if available, because you can actually image just for longer periods of time, and that will increase the counts that you have for the evaluation of a pulmonary embolism. So that's a really effective way for imaging in these patients who are very large. Another group that I'd like to kind of bring to your attention is the trauma patient. So in our population in the United States, it's been demonstrated that about 2% of patients in the setting of acute trauma will have PE. It's probably because there's an injury distally, and that's damaged the vessel and has resulted in embolism to the lungs. So always, even if you're in a level 1 trauma center and you're looking at a PE protocol, take a moment, or even a trauma CT, take a moment to look for PE, because they're pretty common in trauma patients. And because these patients often are admitted and they often are dormant in the hospital, they have a much higher incidence of PE than other patient populations. It's said up to 10%. So you can see here, this was a patient who had PE in the setting of trauma. This patient had had a pelvic fracture, probably had an injury to the external iliac vein on the left, and that resulted in a thrombus to form and then embolism. So trauma is not something that we should forget about. Another controversy that sometimes comes up in acute pulmonary embolism imaging is the subsegmental pulmonary embolism. One question arises, well, what happens if I see a PE and it's a very tiny PE, as in this one, where you can see it's just one small pulmonary embolism in a branch of the anterior segment of the right upper lobe? Well, it's been said that if there's a one subsegmental PE, this actually increases the ability to have another. And it's also said that technology has allowed us to see more of them. So in many centers, what is happening now is these patients will go on to get a evaluation for deep venous thrombosis. If that's present elsewhere, the decision is easy to anticoagulate. If it's not, then many clinical physicians will use the risk factors, will use the history, and will sometimes either start anticoagulation at a lower dose, Sometimes they'll withhold anticoagulation, but there's no uniform approach to the subsegmental PE. And so it's very important to realize that it's easy to kind of ignore them. We don't want to necessarily ignore them, but we want to help the clinician put them into clinical context to see if this patient needs to go on to get treatment. Now, if you're not comfortable, is this a real pulmonary embolism or not, as in this example, let me remind you, a good approach is to look at the lung windows to see if there's any motion. So you can see there's no motion here. The other is to look at the multiplanar images. A true pulmonary embolism should be visualized very crisply on all three planes. And you can see here, very crisp on the axial, very crisp on the coronal, and very crisp on the sagittal. So really useful to have that. Well, what about mimics? Are there any mimics to pulmonary embolism that can make it really challenging? The answer, of course, is yes. You can clearly be hindered by motion artifact, bolus artifacts. These can happen, especially as you start to get newer technologies. Sometimes you'll see a filling defect in the wrong tube. For example, this was a thrombus that had formed in a pulmonary vein. The original reader thought that this may be a pulmonary embolism. Obviously, tumors, and the acute aortic syndrome and prior surgery can be as well. So let's talk about those. So here you can see this is a patient where we had a filling defect in the right lower lobe. The original reader thought this possibly could be pulmonary embolism, but when we apply our rules, is it distinct on the multiple planes? The answer is no, it's not. And this is very typical of what a flow artifact will look like. Very ill-defined, very smoky. Notice how extreme my windows are to bring this out. All of these very, very typical of a flow artifact. I want to share with you another potential flow artifact. You'll notice in this patient, the patient has a very big heart, and this is because they have a decreased cardiac output and they've got a history of heart failure. You'll also notice that the pulmonary artery is opacified, but the aorta is not. And we see these filling defects, but these filling defects are in the anterior aspect of the pulmonary arteries. What these filling defects represent are flow, but they're flow from bronchial arteries. So this is a patient who has congenital heart disease. You may see that there's an overriding aorta in a patient with a history of a previous tetralogy Fallot. Big bronchial arteries, which we don't see here, but you can see that the flow, bronchial arteries anastomose with the pulmonary arteries, and their flow will be seen anteriorly in the lower lobes. So if all you see are these ill-defined filling defects in the anterior portions of the lower lobe pulmonary arteries, think for a moment, is the aorta opacified? And if the aorta is not well opacified, then keep in mind that this may represent unopacified bronchial artery inflow. And this will not be seen if the aorta is opacified because they will also have contrast and you won't see them in the background. Another example of a flow artifact. This was a patient who had a history of had this shortness of breath, and you could see that there was this phenomenon of these areas that were ill-defined. We brought the patient back, and we could see that these were all areas that were not true pulmonary embolism, but we could also see that there were all these areas of bronchial impaction. And so two things, flow and impaction, kind of confusing for pulmonary embolism, but there was no pulmonary embolism present here. Another example of flow artifact. This is a person who had been imaged on our new photon counting detector CT, history of emphysema and pulmonary fibrosis, severe pulmonary hypertension, but notice how smoky the flow is. It looks almost like a smoke cloud, and you could really appreciate how this flow artifact could be confused for pulmonary embolism. And to be honest, this is something we've noticed is true in our photon. The photon counting detector CT is much more sensitive to these flow phenomena, so it's useful to know about. Here was a patient who was brought in who we thought might have a pulmonary embolism in the lower lobes, but when we looked at the lung windows, you could see there was a lot of motion artifact. Well, we called the technologist and asked what was going on. She said the patient had hiccups. So the patient was hiccuping during the examination. So we brought the patient back when the patient's hiccups had stopped, and you could see that all of these were flow-related phenomenon. Now, by the way, this was done with a high pitch mode to try to overcome any potential of any motion artifact. Another common artifact, and to be quite honest, the most common artifact in our practice is something known as transient interruption of the contrast column. In this situation, a patient will take in a deep breath, and the deep breath will be taken in as the contrast is flowing in. What the deep breath will do is it will bring in blood from the IVC, and the IVC is unopacified, so it acts like a saline interrupter. And the net effect is the superior vena cava will have blood that's interrupted with unopacified inferior vena cava blood. So now the pulmonary arteries are not opacified, and the aorta will have a little bit of contrast within it. And this, when you see it, is not indicative of a shunt, but it's indicative of this transient interruption of the contrast column. So what can you do when you see this? This is, by the way, more common in younger patients where there's a much higher blood reserve in the lower extremities and in the inferior vena cava. So what we can do is we can actually tell the patient to either stop breathing or to hold their breath. And when we do that, what we see is that there is now, this is with the patient stopping breathing. So we start the contrast and we just say, stop breathing. Don't take in a deep breath and hold it. Just stop breathing. And what you'll see is that you get much better opacification of the pulmonary arteries and the flow artifact is gone. Sometimes if patients can't hold their breath, one of the things that we like to do is we will have the patients come in and we will bring them in and we will have them come in with this kind of just a high pitch mode. And we'll just say here, this is a pitch of 3.2. And what we'll do is we'll say, why don't you come in and we'll just do the scan with you freely breathing, as you can see here. And so this net effect is that we get this beautiful opacification of the pulmonary arteries. Now, I do want to say that there is something that you can often see that with these guys that I do want to kind of bring to your attention, and that is that it is very tempting to think that the PE study is a study that will answer all of your questions. And the answer to that is that it frequently will not. And that is if you're worried about looking at the mediastinum, if you're looking at the serosa, if you're looking at a patient who you are worried about these other areas, then those patients really deserve a dedicated chest CT. So here, just to show you an example, this is a patient who has a chest pain, and you can see that this chest pain is something that we evaluated the pulmonary embolism protocol. And you'll notice that the pulmonary arteries are not, there's no pulmonary embolism, they look just fine. But if you look, we brought the patient back because of chest pain, and this is now a dedicated chest CT. And on the chest CT, what you can see is that there is enhancement of the pericardium. And this person actually had a pericarditis. So it is very, very easy to overlook the findings of a pulmonary embolism, a serositis or mediastinal lymphadenopathy on a CT angiogram, because it doesn't give us enough time to look at doesn't give enough time for contrast enhancement of the serosa and mediastinal lymphadenopathy. And so really useful to keep in mind when you are looking at these patients and you're kind of in that boat. So I just want to share with you again that when you are looking at patients who are, you are thinking about acute pulmonary emboli, it's really useful to have this 1, 2, 3 approach. It's useful to make sure that you're looking at the filling defects to see if the filling defects are central or if they are peripheral. If they're expansile, they're much more typical of acute pulmonary emboli. But you also want to see what's going on with the right heart. You can see here, for example, there's bowing of the septum, of the atrial septum, of the ventricular septum. There's not right ventricular hypertrophy. So now this gives us an idea of what's going on. And then you can see that there's some changes in the lung. Now, we finished a little bit early, and so that gives me some time to just kind of highlight some of these other emboli that you may see. So here, an example, this is a patient who came in with pulmonary hypertension, and we use that 1, 2, 3 approach. We look and we see that there are filling defects, and at first we thought, could this be acute PE? But you'll notice here that these filling defects are not these central expansile, but they're webs that are present. And here you can see there's right ventricular enlargement, but there's also right ventricular hypertrophy. This is a kind of a nice example where there's some subtle mosaic attenuation and bronchial arteries are enlarged. This patient went on to get a VQ scan just as part of the workup. And as you're not surprised, this is going to be chronic PE. So chronic PE, as we mentioned, is a form of embolic disease But what chronic PE is it represents a form of pulmonary hypertension that may be curable. This is scarring that is developing from a PE. So here, these two images represent what we hope. Here's a patient with acute PE, filling defect in the pulmonary artery. And notice after 2 weeks of anticoagulation, the filling defect is gone. But in 3% of patients, and up to 3% of patients, they may start to develop scarring. And this scarring will result in enlargement of the pulmonary arteries, and it will result in increased vascular resistance. The net effect is pulmonary hypertension, and this pulmonary hypertension is something that may be mitigated and may be improved with an end arterectomy, may be improved with balloon pulmonary angioplasty, which is a relatively new technique, or may be improved with certain medications. Again, with chronic PE, we look for eccentric filling defects, very different than what we saw with the acute PE. And here you can also see that we've got these areas of mosaic attenuation, which are very typical. When we use that approach of looking at the pulmonary artery findings, looking at cardiac findings, lungs, and mediastinal findings, with chronic PE, we tend to see these webs, we tend to see these areas of occluded vessels. Sometimes you can see complete occlusion. We look for mosaic attenuation. We look for right ventricular enlargement and hypertrophy. And occasionally you'll see, in addition to the big bronchial arteries, occasionally you'll see some lymphadenopathy, which is also very typical for chronic PE. Just another example, this is a patient with chronic PE. In chronic PE, you'll notice that we've got these very big bronchial arteries. The mosaic attenuation here, not so profound, but you can really appreciate the big bronchial arteries, right ventricular enlargement, right ventricular hypertrophy. Here is the web-like defect there. This was a patient who had chronic pulmonary hypertension as well. Let's switch gears and show just one other example. Another example of something that I want to make sure that we're all aware of is something known as an in situ thrombus. So the in situ thrombus is something that may be seen in patients that have pulmonary hypertension, and the pulmonary hypertension, when it's long-standing, may result in atherosclerosis of the pulmonary artery. And that's what we're seeing here, where we can see this eccentric filling defect, usually along the greater curvature of a vessel, either on the left or on the right. If we go through our checklist, we should see enlarged pulmonary arteries because these patients almost always have pulmonary hypertension. But if we see that there's going to be the lungs should not have mosaic attenuation, and that we should see that the right ventricle will be enlarged with hypertrophy because of the long-standing hypertension. You may see enlarged bronchial arteries on occasion, and if you do perfusion imaging, you will see that the remainder of the lungs, other than for this filling defect, are fine. So if we look more peripherally, we'll see that there's filling of all the pulmonary arteries, there's no webs. It'll just be this isolated central structure. I want to just go back and share with you, occasionally you'll see an in situ thrombus in the setting of a patient who's had surgery. This is a patient who had a pneumonectomy and developed a small in situ thrombus. This is not usually associated with pulmonary hypertension. This is just an incidental finding. Both of these patients, when there's in situ thrombus from a surgery or atherosclerosis, they will not get anticoagulation for this finding because this is not embolic disease. This is just developing in the setting of severe pulmonary hypertension and stasis. So one of the questions that always comes up in our practice then is, how do I tell an in situ thrombus from chronic PE because they can look similar? So let me share with you two different patients. One of these patients has chronic PE and one of these patients has in situ thrombus. So we see that both of these patients have these eccentric filling defects, but we notice only one of these patients has mosaic attenuation. The other one does not. And if you notice, this person actually even has some corkscrew vessels. If we look at the perfusion images, you can see that this above the yellow line has multiple segmental perfusion defects, whereby below the line, the perfusion is normal. If we look, there's big bronchial arteries. If we look at this patient, there is not. So above the yellow line is a patient with chronic thromboembolic pulmonary hypertension, and below the yellow line is a patient with in situ thrombus atherosclerotic disease in the setting of portal hypertension. And so it can be very useful to just focus on if you just focus on the pulmonary artery findings, it's easy to confuse the two. But if you start to expand your search pattern in the setting of embolic disease to include the lungs, to include the heart, to look for bronchial arteries. It can be very useful in expanding your differential diagnosis and separating what is chronic PE from a patient with inside to thrombus. Now, what about this patient? This is another patient who has a filling defect. And we look obviously very closely and we see that there's this expansion. And boy, we're worried, could this be a large pulmonary embolism? But we see that it's very unilateral. The patient was relatively asymptomatic. And of course, there's an FDG PET that shows increased uptake. This is very typical for a rare tumor. The tumor is a sarcoma. The sarcoma of the pulmonary artery arises from the intima, so it's known as an intimal sarcoma. And a good reminder that intimal sarcomas are associated with big bronchial arteries and expansion, and these are patients that tend to be fairly asymptomatic. So if you have a large pulmonary embolism and the patient's asymptomatic, a little bit of a disconnect as to why that is. Don't forget about a sarcoma. So what about this next patient? So this next patient comes in with septic emboli, and I just want to share with you, septic emboli is just an example of how not all embolic disease will present with filling defects. So oftentimes with septic emboli, the main finding is going to be cavitary, like infarcts, peripheral airspace opacities. Don't always expect to see the filling defect in the setting of septic emboli. You might see vegetation, you might see findings of valvular regurgitation, but don't always expect to see the filling defects. If you have a patient who's febrile and comes in with these peripheral cavitary lesions, this is enough for septic emboli, and they should check blood cultures. Here's a patient who had a septic shoulder, and you can see they had septic emboli. And being aware of, you may recall that finding that we described earlier with acute PE of that thick-walled reversed halo, as we see here. When we see these findings, useful to think about infarcts, and especially when many of them are cavitary, some sort of infected infarct, septic emboli. In this patient, no filling defects were seen, but this person actually had a thrombophlebitis of the jugular vein, the so-called Lemire syndrome, presenting with septic emboli. And just to share with you here examples, again, of septic emboli. A reminder that septic emboli really relies on the parenchymal findings, not the vascular findings. So useful, both of these patients, septic emboli, neither of these patients had filling defects in the pulmonary artery. Above the yellow line, this patient had a filling defect in the internal jugular vein, very typical of septic emboli. And what I want to mention to you is that we are seeing now with increased frequency, especially with our newer scanners, that we can see that sometimes patients with septic emboli will have very tiny filling defects, but they're not very common. But sometimes they'll also start to develop pseudoaneurysms of the pulmonary arteries. So whenever we suspect septic emboli, we always look for pseudoaneurysm formation because it is something that we may detect. Usually, these patients will be followed, but if the aneurysm is large, they may go on for coil embolization because they are predisposed to rupture when they get very large. I want to share with you another one final entity, and that is there's something known as tumor emboli. In microscopic tumor emboli, another example of embolic disease that you might not see the filling defects in the pulmonary arteries. Now, if they're macroscopic tumor emboli, where, for example, with renal cell cancer, we often will see these. But with the tumor microemboli, we have to always be mindful that we might not see filling defects, but what we will see is because of the increased vascular resistance, the right heart will enlarge. We may see tree and bud opacities, but unlike what we're used to seeing, these tree and bud opacities are not of the airway, they're of the small vessels. And we may see other findings, such as a malignant pleural effusion or the primary tumor. So these are three different examples of patients having a small, tiny kind of tree and bud opacities, central lobular nodules, and all of these patients had tumor microemboli. Very challenging, difficult diagnosis to make, but these patients are usually markedly short of breath. As you can see here, they have these tiny little nodules, which we might confuse with tree and bud opacities, but again, they were all very short of breath in the setting of tumor, and these are examples of tumor emboli. You can see the right heart is mildly enlarged here. Knowing about this entity can be very useful because it may explain some very strange phenomenon. So for example, this patient was markedly short of breath and received a pulmonary embolism protocol. And on our first glance, we saw no pulmonary embolism, but we all appreciated the right heart had gotten much bigger. And there are these very tiny ground glass opacities. This patient had a history of ovarian cancer, and we could see the change in the heart, and we were suspicious that this patient had tumor microemboli. Unfortunately, they progressed, and this patient ended up expiring from their microscopic diffuse tumor embolic disease. Another patient with gastric cancer, this person, I think we all could pick up the lymphadentic spread. And so when we saw these beating of the pulmonary artery, very typical of tumor microemboli as well. And so we were able to make that diagnosis. Again, tumor microemboli, very different than the macroscopic tumor emboli that you may see with the filling defects. And the macroscopic tumor emboli will often have enhancement of the emboli, very typical of what we might see. And so with this, I'd like to terminate my portion of the discussion because I just wanted to share with you what our experience was and has been with pulmonary emboli. Just to recap, it is important when you're looking for embolic disease to have a checklist. Look beyond the main pulmonary arteries. Of course, we're looking for filling defects, which help make the diagnosis, but it's important to look at the lungs. Do you see mosaic attenuation? Atypical for acute PE. Do you see cavitary infarcts? Again, that makes us think of septic emboli. Look at the right heart. Is there right ventricular enlargement? That might be suggestive that it's going to be massive or submassive PE. Is it hypertrophied? That suggests it's something that's longer. Do you see bronchial artery enlargement, which is going to be much more typical of something like chronic PE or Eisenmenger syndrome than it is for acute PE? And of course, looking at the lung parenchyma, do we have mosaic attenuation, more typical of chronic PE? Do we see infarcts? Are the infarcts cavitary? And if we can have this search pattern, this checklist, I think it really helps us make more of a difference in identifying what the filling defects are, and also helping when the embolic disease is not typical of thromboembolic disease, namely tumor emboli, or if it's something along the lines of something like septic emboli. And with that, I know it's everybody's Sunday, so I'll stop talking. I thank you so much for your attention. Again, my email is, let me see if I can bring this back to the beginning of our talk here. We'll come back to the beginning of my talk here. My email is Sanjeev Bala at worcester.edu. And I think that is something that I would encourage you, if you have any questions, feel free to email me. So I will go ahead and I'll stop at this point, and I'll turn the panel back over to Dr. Aaron. Dr. Aaron.
Thank you, Bala, for the wonderful presentation that you've given us. At this opportune moment in time, I would like to go straight away into the Q&A sessions. So if you have any questions, please go ahead and put them in the Q&A sessions. We'll try to answer as many as possible. So right to the first question, could you explain the pitfall related to breathing in a young patient?
Yes, for sure. So if you are imaging a young patient, the young patient will have a very large amount of blood in the inferior vena cava. So if you say, take in a deep breath, what will happen is the blood from the inferior vena cava, where there's no contrast, will come up into the heart, and it will stop the contrast from flowing into the heart. So the net effect is you get the pulmonary arteries will often be unopacified. And so instead of telling the young patient, take in a deep breath, just say to the patient, take in a breath and hold it, or just stop breathing, and you can avoid that artifact.
Thank you. Next on our panel is, could you explain the pulmonary artery webs again?
Yes. So with chronic pulmonary embolism, you may see a web instead of a filling defect. The web actually represents a scar, and the scar results from the inflammatory reaction to the thrombus. So these webs actually are more like just kind of undermined scars that are present, not actually embolic disease from the legs.
Okay. How to diagnose stage of PE based on time of imaging?
Oh, so the stages of PE, was that the question?
Yes, how to diagnose the stage of PE, yeah, based on the time of imaging.
Yes. So, so it's one of I think this is one of the questions that comes up a lot is people would like to know how old is the pulmonary embolism based on the CT. As a general guideline, a PE should have very sharp borders. And so if you see a PE where the border is somewhat fuzzy or irregular, it suggests that it's days old. And most pulmonary embolism, if you can see it still with a significant amount of mass, is usually within a couple of weeks. It's hard to get to the exact day, but as a general guideline, if the borders are fuzzy, it suggests that it's greater than 24 hours. And if it has still some mass, it suggests that it's less than 2 weeks.
Thank you. One more question to go.
Sure.
So in a patient with history of primary cancer in TB endemic region, do we need to suspect all 3 in bad nodules with microembolic tumor?
That's a great question. What is useful in TB endemic regions is to look for air trapping. If you see air trapping, it's much more likely to be TB than it is to be tumor emboli. Tumor emboli don't result in decreased perfusion to that area, so it's unusual to get areas of decreased attenuation distal to the tree and bud, whereby with TB, it's much more common. The other thing is tumor emboli don't tend to have cavitation, whereby TB will have areas of cavitation, especially when there's tree and bud opacities. And so I think looking for cavities and looking for air trapping will also help. And then the third is look at bronchial wall thickening. Bronchial wall thickening should be absent in tumor emboli, whereby you might see that with TB. So really looking for airway-related findings can be helpful in making the distinction.
Thank you very much. This brings us to the end of our open questions. Yeah, there being no more questions. Okay, I think one final one has come. And after this, I'll hand you over to Nate. Do we need to differentiate septic embolism with cavitating lung metastasis?
That's a great question as well. That cavitary lung metastases, as we all know, are very common in practice, including when you have squamous cell cancers, which are known for cavitation. As a general guideline, squamous cell cancers, when they cavitate, have air in the center, so it'll be black. There may be an air fluid level inside those cavities, but they are black. Whereby septic emboli, when they cavitate, they are not purely black. You'll still see areas of kind of bubbly lung in them. And so there's some internal architecture, which is usually absent in the setting of cavitary metastases.
Thank you. I would like to take this opportune moment of time to thank you, Dr. Bala, for making the presentations and also able answering the questions. So without further ado, I would like to hand over the participants to Nate. Thank you.
Thank you for your moderation.
Thank you, Dr. Bala. I'm going to start our quiz question. Please feel free to leave if you need to, please.
I must head out to another call, but Nat, thank you for having me and thank you all for joining us. I wish you all a great day.
Thank you too. Thank you. All right, so we are now at the quiz question. Can I share my screen? I'm going to share my screen. Wait, just bear with me just for a second. Okay, hold on. Oh, no. Okay, hold on. I'm going to share it. Okay. Okay. All right, I'm going to turn this on. Okay, so we are now at the quiz question. The question is, so have your phone ready to scan this QR code, and then I will give you today 2.5 minutes to finish this because some places have slow internet. Okay, today gonna be 2.5 minutes. Okay, after I'm done, I'm gonna say to you, I'm gonna time it up. What finding is most relevant to the patient's clinical outcome? Is finding A, finding B, C, or D? Okay, so now have your phone ready to scan the QR code, and then I'm going to time it. I'll give you 2.5 minutes today. Okay, I start now. Now, is this most what finding has the most impact on patients' clinical outcome? Is it finding A, B, C, or D? Right. Dr. Bala has emphasized on this finding as well in his talk, in the middle of his talk. One and a half minute left. And at the end, please do the survey. Anyone in Thailand, anyone who participate in this will get the CME, but the rest of us will not get the CME credit. But if you do the survey at the end, we have a QR code for you to scan and do the survey. Whoever that do it will get the certification of attendance, and it will be sent to you to your email address. 40 minutes left, 40 seconds left.
Hi, Dr. Nat. It says that it's no longer accepting the response.
Oh, probably, I'm sorry for that. I'm going to stop sharing now. Not stop sharing, I'm going to share it again. And then, thank you, Dita. I think the IT give you only 1 minute. Let me share it again. So we're going to go over, at least we can go over this question. So,
Ada dokter untuk bisa masuk di kelas-kelas yang lain tadi itu.
the choice A, what does it mean here? What I'm trying to show you here, do you see my screen, Dita?
Yes.
Gitu ya.
My here you see opacity here in the periphery of the left upper lobe here. I want to show you pulmonary infarction. And the second one, we see the small PE here. And then look at the PA diameter is bigger than the aortic diameter. So I want to show you dilated main pulmonary artery. And the third one, I did the short axis of the heart. I did not do it on 4-chamber or on axis, on the straight axial. So I want to show you right heart strain. You can see that my interventricular septum is bowing toward the left ventricle, and my right heart is bigger than the left heart. That is a right heart strain that we do RV to LV ratio. Is more than 0.9. We consider it is a right heart strain. And the last one, I want to show you pulmonary edema. You can see we have interstitial interlobular septal thickening and a little bit of atelectasis or pulmonary edema. You also see findings of volume overload here. All of these patients has PE. The most clinically relevant one is this right heart strain. It impacts the patient's clinical outcome. No one talks about pulmonary infarction. Dilated main PA, you can see in chronic pulmonary hypertension may not be so related, and there's nothing to do with pulmonary edema. So the correct answer is this one, is C. Okay, and this is from this paper. They have project trial is from a long time ago, 2014. But this paper conclude about the right heart strain, and they measure the right heart to the left heart ratio on straight axial. But I do it on the short axis of the heart because I want to emphasize about the septal bowing toward the left ventricle. So that is my quiz question. And then I think you can, IT, can you show the evaluation so they can do the evaluation after this? The QR code for the evaluation. So please do the evaluation. If you want to get the certification of attendance, please do it. But if you don't need it, that's fine. And in April here, if you answer to right question from this month, you will get this, the AirPod 3. I send it to you wherever you are. And the last person who joined, the last gift, it will go to Mongolia. I will mail it out on next Monday. The last month is to Mongolia. So this month is maybe yours. So please do the quiz, and then we will. I send you an email. Whoever that got selected. Okay, JP, I'm done here.
Oh, thank you, Nat. Thank you. Thank you. It was a wonderful session. Thanks, everyone, for joining. And don't forget to join our next session, which is on Coronary CTA 101, which is on Sunday, 21st April by Dr. Smita Patel. It will be an excellent lecture, another one on cardiac CTA,
Yes.
especially in the coronary arteries.
Yes.
And I'd like to thank all the attendees for participating. I'd like to thank all the committees, IT committees, especially Dita, Dr. Nat, and Dr. Aram, one of our moderators. Thank you all so much for joining us.
Yeah, one more thing about Dr. Patel. Since I've been working with her this talk, I have not worked with her talk, but I have seen her talk. It's a very good talk. They're very easy, and she has a ton of cases to show you. If possible, and you are interested in cardiac imaging, I think please do not miss it. You will miss a big miss here if you miss it. It's really, really good talk. I saw it last week.
Yeah, correct.
Okay.
Agree. All right.
Okay, we'll see you on the third week and third Sunday of this month. Thank you.
Thank you.